All right, good afternoon, everybody. That was kind of quiet. Let's try that again. Good afternoon. All right, that's a little bit better. Hi, my name is Christopher Schott. I'm here from Pittsburgh, the VA Pittsburgh and University of Pittsburgh. I'm really excited about this session that we have put together for you guys today. We have two big themes we want to cover. The first is we're going to do a review of the updated SCCM guidelines for point-of-care ultrasound use. And then the second part I'm particularly excited about, which is going to be an interactive session where we're going to provide a framework for how to interpret ultrasound images, focusing on something we've started to call cognitive focus. So I'm going to warn you guys in advance, this is going to be interactive. So I'm going to be walking up and down the aisles, and I hope you guys will be able to participate. So we'll show you images, and we're going to ask you to come up to the microphone and give us your thoughts on each of the images. As a medical educator, I am very comfortable with uncomfortable silence, so I will just sit and be quiet until somebody does come up to the microphone and answer. So the sooner you volunteer, the less awkward it is for everybody. But again, the more we'll get out of this, particularly at this time of the day. I know when people are getting tired thinking about what they want for dinner. So hopefully this will be a nice, fun wrap-up to your afternoon. I am incredibly excited by the panel we have here today. I have known each of them for many years at this point. I have an introduction I'm going to read for each of them, but I don't think it covers all of their accomplishments. So just to get started, I have Dr. Aarti Sarwal. She is a professor of neurology at the Virginia Commonwealth University School of Medicine. She is a neurocritical care physician with significant experience in program development, education, and quality improvement. She is board certified in neurology and neurocritical care with specialty certifications in clinical informatics and neurovascular ultrasound. She has built the neurocritical care program at Wake Forest School of Medicine and has held roles of section chief, neurocritical care medical director for the Neuro ICU, fellowship director for neurocritical care fellowships, co-director for undergraduate School of Medicine integrated ultrasound curriculum, and assistant director for the fourth-year medical student POCUS elective at the Wake Forest School of Medicine. She is the associate editor for critical care medicine and social media neurocritical care. Her personal research interests focus on the use of neurosonography for assessing cerebral hemodynamics, point-of-care applications of ultrasound in the ICU, intracranial hemorrhage, diaphragm ultrasound, and ventilator-induced muscle dysfunction. Her professional interests also include enhancing use of social media and informatics in academic medicine to improve patient and provider experiences. I don't even think that covers half of what she does, to be honest.
Next, it's impossible to follow that, so I'm just going to say that.
Next, we have, just in the list, my order, at the far end, Diane McLaughlin. She is a nurse practitioner at Barrow Neurologic Institute in Phoenix, Arizona. She has worked in critical care medicine for over 20 years. She is active in national organizations and has served as the chair of SCCM's APP Resource Committee, and is the current chair of the nursing section APN Professional Development Committee and future chair of the 2027 SCCM Annual Congress. She has also served on the Ultrasound Committee, ACCM Rewards Committee, and Strategic Planning Committee. She has been in faculty for both SCCM, AACN, and NCS ultrasound courses, and has been an international speaker at multiple society meetings, particularly speaking on POCUS and neurocritical care. She's also active in the Neurocritical Care Society, having served on both the Guidelines Committee and APP leadership, and is an active member of Social Media Ambassador. And then finally, we have Dr. Sarah Bain, a cardiac anesthesiologist and intensivist at the Virginia Mason Hospital in Seattle, Washington. She has received her medical training at George Washington School of Medicine and postgraduate training at Stanford University. She's held the roles of Division Chief for Cardiac Structural Heart and Thoracic Anesthesia and the Associate Program Director for the Anesthesia Residency for the past several years. She is now the Hospital Point of Care Ultrasound Director for the Virginia Mason Medical Center. She has been both the Vice Chair and the Chair of the SCCM Adult Ultrasound Committee from 2022 to 2024 and is currently the Co-Chair of the SCCM Ultrasound KEG and SCCM representative on the expert panel for International Consensus Conference for Point of Care Lung Ultrasound 2.0. So these are incredible experts that we have here, and I will now turn it over to Dr. Aarti Sarwal to give us a review of the updated SCCM guidelines on point of care ultrasound.
Thank you, Dr. Schott. If the AV folks can see if there's an echo in the room, at least on our side. Now, I know many of you can't see me, but I'm sure everybody can hear me. So till you get the content, we're great. So no relevant disclosures here except for a few ultrasound-related activities. So I'm very proud to be and very honored to be a part of this phenomenal group of educators. If you thought we were achievers, Dr. Schott himself is a globally recognized medical educator. This was a phenomenal group of global POCUS experts that got together and looked at a very focused subset of critical care ultrasound and its use. We were helped by the great group of methodologists. It was a fairly international panel, but represented by high resource income countries, as you can see. 26 panel members from United States, rest from Canada, France, Switzerland, and UK. The focus was not low resource setting, which is another guideline coming up as well. It was focused on adult population. We did not address pediatric patients specifically, mostly because of the lack of paucity of definite data for any recommendations. This is the guideline infographic that you can download on the CCM website. This is online as of, I think, 2 days ago. The guidelines defined critical care ultrasound as point of care ultrasound that is performed and interpreted by the treating clinician of critically ill patients, regardless of the hospital setting, to augment diagnoses, manage care, and guide invasive procedures. So defining that at least defined the scope of what we considered was critical care ultrasound when we looked for articles and evidence in relation to the questions we asked. And there was a strong presumption. We are by no way recommending or suggesting that anybody who just learned ultrasound yesterday can go and implement these guidelines. The presumption was that practitioners performing critical care ultrasound have appropriate equipment, training, and competencies when they're performing this ultrasound. So with these presumptions, if you are new to reading guidelines, when we make recommendations, we either say we recommend doing this or we say we suggest doing this. And you will notice that in these guidelines, most of the evidence supported statements we made, they were suggestions, they were not recommendations. So how to translate that? When you use this framework, you're basically looking at implications. The benefits of the intervention are not very certain. So when you suggest it, that doesn't mean everybody should be doing it. That basically means that the evidence at this point doesn't quite tell you that it's mandatory. But whenever possible, whenever the situation favors it, this is something you could use. When it comes to patients, majority of the individuals, if given that situation, would want that recommendation. So recommendation is you should be doing it in every patient. Suggestion is majority of the times, if you were to make a choice, you will end up doing this intervention. And when you look at clinicians' part, again, different choices are likely to be appropriate for different patients. And when we make a suggestion, we're basically saying, take into account the circumstances, the patient, and the clinical scenario. And then when it comes to policies, when we say we don't do that here, or our policy says this, or can we take these guidelines and make them policy that all sepsis patients should use ultrasound now? Recommendations can probably translate a little more strongly into what should be done, but when we suggest, that doesn't mean that evidence is high enough, and we still need more debates, we still need more stakeholder involvement before we can transition these statements into policy. So with that caveat in mind, make sure that all the 5 recommendations that I'm going to study, these are not mandatory statements, these are suggestions for use given the evidence that we have. So with the new SCCM approach, we are being very practical with the guidelines. So we give you 5 questions that are very clinically relevant to clinical practice that's going to change your practice tomorrow. So the first question we addressed was, does critical care ultrasound in adult patients with cardiac arrest help you improve outcomes compared to standard of care? For these, we looked at multiple outcomes. We wanted this an encompassing recommendation. So at the bottom, you can see we looked at signs of organized myocardial contraction. We looked at ROSC, we looked at time of ROSC, we looked at how many times it interrupted CPR versus not interrupting CPR. All of us have shared concerns about ultrasound sometimes interrupting CPR. We talked about ICU length of stay, mortality, neurological outcomes, any outcomes we thought could be relevant to clinical practice. We found 13 observational trials and 1 RCT only, so you can see the paucity and the significant research gap that exists in this field. At the end of the review, we couldn't find a single study that really had a measurable effect enough to make a strong statement. There were contradictory reports from the limited studies available. So in the end, we ended up saying, if you do it, that's okay. If you don't do it, that's okay as well. So in cardiac arrest, the best statement we could make was that we suggest either using ultrasound or usual care without ultrasound. At this point, given the evidence, both are equivalent. Now, we did notice a few studies that made us put special consideration that if performed by a proficient operator, given the low risk of TTE and known diagnostic accuracy, the use of ultrasound may be used as the preferred method to guide resuscitation during cardiac arrest. And you can see the caveats applied here. So that was the first statement we made. The second population we looked at was septic shock. All of us are familiar with the value of ultrasound here. We found about 11 RCTs that had a little less than 1,000 patients. We compared ultrasound-based resuscitation and hemodynamics versus standard of care for septic shock patients. And the challenge we found was that there were different ultrasound protocols used, significant heterogeneity on what was used, and when ultrasound was used to guide patients' resuscitation. First 3 hours versus 72 hours later versus 5 days later. Despite this heterogeneity, when we looked at various outcomes ranging from mortality, length of stay, use of inotropes and vasotropes, and each time when we looked at a question, we tried to formulate outcomes that were specific to that particular question to see if there is clinical benefit. We looked at dialysis, and we also used invasive mechanical ventilation and vent-free days as an outcome, just because the side effect of too much volume typically is prolonged mechanical ventilation. With our analysis, we found a small mortality benefit given the limited number of studies available, and we were able to make a statement that we suggest the use of critical care ultrasound in the management of adults with septic shock. And when we say critical care ultrasound, this is all comers, cardiac, lung, everything combined. We did notice a special consideration that for initial as well as ongoing assessment, when you have sepsis or septic shock, if you have access to machines, if you're appropriately trained, there definitely seems to be a signal for using it. The third scenario we encountered was acute dyspnea or respiratory failure, which is another thing that brings patients to the ICU. We found 18 trials, little more evidence than the previous 2 questions, a little over 3,500 patients. And in this case, in addition to the traditional outcomes like mortality, length of stay, we looked at percentage of patients that would eventually need oxygen therapy as a sequela of too much resuscitation. We looked at the subgroup with weaning, and we also looked at the need for additional diagnostic tests and tools because ultrasound found something. So that was a unique outcome we looked at here, and we found there was a significant signal in the reduction in duration of mechanical ventilation by using ultrasound with guided resuscitation, reduced time to reach the correct diagnosis and treatment, and absence of increased adverse outcomes. There was no report that adding ultrasound increased adverse outcomes in patients with respiratory failure. And we did find heterogeneity of the protocols used. You all are aware of some different protocols for incorporating dyspnea and shock evaluation, and we did not find any certain evidence favoring one protocol over the other. The fourth question we tackled was targeted volume management. All of us are learning ultrasound resuscitation strategies from the perspective of precision clinical medicine, titrating volume to that particular patient's clinical status, and fluid responsiveness, fluid down, fluid up are such a big matter of contention that there is a whole conference dedicated to it if you're aware of that. So we looked at about 18 RCTs, again, lots of data from about less than 2,000 patients, not a big sample size. And we found again, looking at the traditional markers of outcomes, we found that there was a trend towards reduced mortality when ultrasound was used for resuscitation for targeted volume management, and fluid balance at 72 hours, which has been shown as a good clinical correlate for many studies. So both were positive signals in favor of use of ultrasound, and a subset of patients that were medical cause of sepsis benefited more than patients with other cause. We also found contradictory evidence in ED studies, but our analysis showed that when volume-targeted resuscitation using ultrasound was used in the ICU, that definitely showed positive signals compared to ED. And the special consideration is, we all know that personalized approach to fluid management is of benefit, but we did find that there's lack of data on the adverse events of incorporating ultrasound into these protocols, and that needs more research. Lastly, we looked at the question of cardiogenic shock, which obviously is the bread and butter of cardiac ultrasound. And in this, we asked the question whether standard therapy versus what we use now as incorporation of ultrasound changes outcomes. We looked at, again, traditional outcomes, but also added some cardiogenic specific outcomes with regards to escalation of support when it comes to MCS, inotropes, surgery, PCI. We looked at weaning of MCS as well when guided with ultrasound. We found 5 studies, extremely heterogeneous enough that we couldn't even pool the data. And we did find signals towards, when compared to pulmonary artery catheters, which seem to be kind of the foundational gold standard for cardiogenic shock, we did not find any evidence of adverse events related to cardiac ultrasound when it was added to the standard of care. When you compare that to the adverse events of pulmonary artery catheters, especially with regards to data interpretation, we found signals of undesirable effects towards the PACs. We all know the paradigm, people don't kill people, swans don't kill people, swans don't kill people kill people because of bad data interpretation. By no means we are saying that carotid ultrasound critical care ultrasound is not vulnerable to bad data interpretation, but compared to PACS, that signal is definitely stronger in favor of ultrasound. And then we also looked at cost effectiveness and found that not using PACS was actually shown to be cost effective versus using PACS. And with that, we were able to say, we suggest the use of cardiac ultrasound compared with usual care. And we did note a special consideration that many cardiogenic shock patients may likely benefit from both, and we obviously need further studies. So I hope this was a little perspective to reading these guidelines. This is the link to the actual guideline. There's a very nice executive summary as well. And as I told you, there's a very nice infographic available. If you have any questions, we'll take it at the end of the session. Thank you.
All right, thank you very much, Aarti. So that was an excellent summary of all of the guidelines. We're now going to transition into the interactive part of it. So I'll invite Dr. Sarah Bain up. I'm going to come down into the audience. Again, I'm going to warn you guys, this is meant to be interactive. So please get ready to stand up, go to the microphones. I've got a laser pointer. So we'll have you guys highlight what are things that you see are correct on the images, what are things that can be done to improve the images, what pathology there is. So I'll be coming down and joining you guys as my attempt at a game show host. So with that, Dr. Sarah Bain.
Sorry guys, I'm just gonna have to flip through this. While I'm flipping through, just remember that this is supposed to be fun. Ultrasound is fun, so don't be shy. Tell us what you think. Okay. Where are my slides? Sorry guys, 1 second, because they were supposed to be.
Go back to sessions.
Oh, there we go. Perfect. Okay. So I'm going to focus on cardiac because I think that's what scares people the most. There's a lot going on in the heart. There's a lot that we can tell and do with ultrasound, and I think if there's anything that is a little bit intimidating for new learners, it's going to be cardiac. Can I just get a share of hands in the audience of those who are comfortable in utilizing ultrasound daily, weekly? Anybody? Okay. All right, so there's also a number of people in here that aren't as familiar, so this is also going to be geared towards you, so we'll see how it goes in the next 15 minutes as we go through. So we like to split point-of-care ultrasound or any ultrasound imaging up into two parts. We've got what we call the kinesthetic skill of actually getting the image. So that's going to be us putting our hands on the probe, putting that probe on a patient. And that takes quite a bit of skill to learn how to do, especially in transthoracic. And I want you to think about that at the level of like learning a surgical skill. So it takes a lot of muscle memory and repetition, and that's going to be where we talk about the psychomotor. And then in addition to that, it's also this visuospatial and visuomotor aspect of it, which can be very hard for certain people, because what we have to do is create a 3D image of that heart in the thorax and figure out where our ultrasound beam is going through and how it's slicing, and then interpret that on a screen. And so that is a whole subset of a skill in learning ultrasound. In addition, you would then have the cognitive skill of the actual interpretation. So once you have that image up, then we've got to put the work in to figure out, well, what are you looking at, what's the anatomy, and then what the pathology is. So what we are thinking is that some people are really good at the skills, and some people are really good at the cognitive aspect, and some people are really good at both, and that's okay. And we can teach ultrasound to all of those people, right? And so this was a meta-analysis about 16 studies that looked at teaching ultrasound, for point-of-care ultrasound at the bedside to learners. And it showed that 26% of that ability to learn and or actually do ultrasound was based on understanding the relevant forms of knowledge, which we can kind of then talk about in that cognitive interpretation. So if you learn how to interpret an image, that is going to help you so much more in doing the physical skills of doing ultrasound. Because sometimes we get a little caught up in the physical skills and people don't actually ever get to that point of good interpretation. Because if you can't interpret what you're doing, even if it's a perfect image, if you don't understand what's on that screen, you're not helping your patient. So we've got a proposed framework, and we're going to kind of and I'm really big on keeping it simple. I think everybody else is too when we're teaching. we're going to start with three questions. We're going to say, what is this view, first of all? And we're going to focus, this is on the cognitive aspect. We're talking about interpreting an image. Then we're going to talk about what's good and what's bad about that image. What makes an image good and that you would want to save and then show your colleagues. And then the next step is what's wrong with the patient. So then we've got the image, we're looking at it, and now we've actually got to diagnose something with that patient. So we're going to walk through this, and we're going to use the parasternal long axis. So I'm not going to go through all of this is not teaching you comprehensive cardiac ultrasound. We're just going to go through this one view. So for many of you, this looks familiar, but this is what we call the parasternal long axis. And you can see we've got a heart, and it's definitely beating. So we're going to go through all of the aspects and the anatomy of this. Okay, so up here, what we want to see in an ideal image when we're looking through at this line of Doppler is at the top of the screen. So remember, your probe is at the top of the triangle. That's where your probe is on top of the patient. So we've got the right ventricle, and then right underneath this is the left ventricle. So this is the septal wall, and then opposite the septal wall is our lateral wall. So then we've got the LVOT and into our ascending aorta, and below that, our atrium, left atrium, and our mitral valve. So we're gonna go over and over and over this, but before even understanding where you put a probe on the chest, if you look at this and can study and remember what we're seeing, then you're one step ahead of the game. And that's what we're talking about in terms of teaching with the cognitive aspect of this first before we even get to the bedside. So now we're going to talk about just really quick where our probe is so you guys can start to get an idea, because you see the image and you do need to understand where the probe is in relation to the heart. So this is our parasternal window, this green window right here. And then, oh, thank you. You're not seeing my mouse, I didn't realize that. Thank you. Thank you guys, sorry, I didn't know you couldn't see my mouse. Okay, so this is that green window, that's our parasternal window. And again, that's all we're focusing on for this short little talk. So when we're putting the probe on, our marker is going to be towards the patient's right shoulder. And just so you guys know, this is the only time in cardiac ultrasound for the basic views that you've got the marker pointed to the right. The rest of the time it's pointed to the left. And what you're seeing is this long axis cut through the heart, and you can see that you're closest to the right ventricle, and then underneath this, and when you're looking at that view, and moving it in that 3D way in your mind, you've got the right ventricle, and under that is your left ventricle, your LVOT, and then your left atrium. And that's what we're looking for in this view. And what we want to see is all of those aspects and chambers lined up in the center of the screen. So again, just to remind you about anatomy and where everything is, but we talk about the long axis plane and we talk about the short axis plane. And so we want to be able, with our probe, to get all of those axes to create a 3D view of the heart in our heads. And that's what we're doing here. So we're gonna focus on that long axis view, which is this over here, with our parasternal long axis view. So here we go. So we've got our view, we've got a name for it. You're familiar with some of the anatomy, and we're going to keep going through this. So what makes a good view? So I mentioned that we've got a few chambers in here, and what we want to see is them lined up. So your RV, which is on the very top of the screen closest to your probe, and underneath that, the LVOT, and underneath that, your left atrium. All of those in diameter should be about the same. So if one looks bigger or smaller than the others, then that should start to clue you in that there could be pathology there. So you want to see those three chambers lined up towards the center of the screen. You also want to see your LV, but what you don't want to see is all of the LV. We want to see the base of the heart and the mid-ventricle, which is over here where our papillaries are. We don't want to catch that apex. We're going to see that in a different view. If you see that apex over here, which is right here, that means you're going to foreshorten that LV and likely overestimate function. So this is an example of a really good view, because if you don't know what a normal good view looks like, you won't know what an abnormal poor view looks like. So looking at these, and when you're teaching it, teach with normal first and say, this is what we want to see. And then when when you're seeing something abnormal or your learner is getting an abnormal view, you're able to, because they have an understanding of what's underneath that chest wall, they can figure out where to put the probe to optimize their image. So now we talked about what makes a good view, so what makes a bad view. So we're gonna just see if, I'm just gonna let this play on loop, and we're just gonna call out, and Chris is gonna let anybody that wants to, what you think might make this a bad view on the left.
All right, so again, this is the interactive part. So if people would like to come on up and start to comment, there are no wrong answers, but we'd like to hear, what do you guys think? What can we do to improve this view? What are things we should be seeing that we're not? Is there any pathology on the views? We won't move on until we get volunteers, so.
We're not able to see the LVOT properly in the left, and as well as I think the ultrasound probe is not as stable. That's why we're getting like an in and out view of the left atrium.
Perfect.
Can you just repeat that, Sarah?
Yeah, so what she said is that we are having trouble seeing our LVOT in the entire view, and that likely the probe might be rocking a little bit or moving, so we're seeing that LV in itself in and out of the actual screen. Anybody else? It doesn't look right, right? We can agree with that. Okay, so we're starting there. So absolutely, and what we're really seeing, and not to get too into the weeds with this, but a couple things, is that initially, when you're first seeing this loop, our LV looks sandwiched together. You're not seeing an open cavity, and then it opens up and looks like a normal LV. That's what we expect. You're seeing the actual cavity. And because of that, you can see that LVOT is obscured when that LV is collapsed, and so you're not seeing an LVOT. And what this is saying is that the probe is likely more medial towards the sternum, and we're catching the RVOT and the pulmonary valve. Now, you didn't have to know all of that, right? You didn't have to know where you might see a pulmonary valve or RVOT, but I think all of you agreed that that didn't look like the one I showed you before. And that's what we're talking about when you're starting to teach this. Before we get into the weeds and get people really kind of nervous and anxious and upset that they're not figuring it all out at once, we're trying to say, take it simple and just start with a simple interpretation. Okay, so now we're going to jump into pathology, and this is where I want you guys to start calling out, just like you did, thank you. So what's wrong with the patient? Because that's the whole reason we're doing this, right? Okay, so this is not, I'm going to try to get these to play. This is supposed to be normal, and I apologize. It's not playing, but the one on the right, does anybody want to tell me what's wrong with that? What's wrong with the patient, not the view? Okay. Perfect. Yeah. Just for the sake of time, I think you guys are all saying the same thing. And what I'm trying to say is that all of us, I think, knows that's not a normal heart. It's definitely not beating like a normal heart, even though you don't have the other loop playing with a normal heart, right? And we could get a little bit more analytic. Hey, maybe something's going on with my mitral valve. Maybe I've got some thickening of one of the walls. But we are globally hypokinetic and in a global cardiomyopathic state right here. So exactly, and this might seem very simple, but if you've never seen an ultrasound image or you're brand new to learning this is the kind of thing that you need to start with. Almost the extremes, right? The extremes of abnormal and then the normal, and then you can fill in the gaps in the middle. And here we go, just to go through it one more time. We start with our right ventricle closest to the probe, because that's the right ventricle is right under our sternum. And then we have our LVOT, our left atrium, and then you can see the descending aorta right underneath. But this is a good view. It's a technically good view. It's just not a technically good heart. Okay, here we go. What's in there? What's going on? Just yell it out. Yeah, there is a big goober sitting in our mitral valve and it should not be there, okay? And again, we would hope that anybody looking at that would say, that doesn't look normal. But again, if you've never seen this, but imagine that being a little bit smaller and might not be as dramatic. But the idea is that you want to see the dramatic stuff too, but you're already seeing that this stuff isn't normal. This is a long loop of the pathology, so we'll keep moving. Okay, so here we go. A little bit more pathology. One, I'm going to ask you guys, what do we think the pathology is? What's wrong with the patient?
Systolic dysfunction over here.
Okay?
Lateral wall motion abnormalities.
Love it. Severely hypokinetic. Okay, so a poorly functioning heart, right? Severe systolic dysfunction. Second question for you guys, is this a good view? No. What is missing on this view? Right, we can't see our RV, so we're not lined up. And are we seeing that apex of the heart, of the LV? Yes. So even though you can see a heart, and you might get this, and you'll be like, oh yeah, that's great, it's so clear. That's actually not a good view. I mean, can you tell what the pathology is? You can. But if you want to make sure and if it wasn't so dramatic, you would really want to optimize your image. And you wouldn't want to make any calls about that apex of the LV in this view. This wouldn't be what you're looking for. So you guys already know right here that that's not what we're looking for. Okay. Pathology. Take a look. Yeah, so I'm going to point out a few things. So we have a very thick left ventricle. Those walls are very thick. So we have global hypertrophy. And then if you take a look over here at that proximal septum, so I know it's the proximal septum because it's close to the LVOT, right? Even if you've never seen this and you've never seen an example of HOCM, hypertrophic cardiomyopathy, or proximal hypertrophy, you can tell that now because you know the anatomy of the heart. And so now we've got a very prominent proximal septum. And then you can start to say, oh, is there SAM? Is there dynamic outflow obstruction? Let's get into it, right? So already you're there, and you could do this with a resident who's never seen an image right now in 15 minutes. Granted that they know about hypertrophic cardiomyopathy. Okay, I think this might be one of our last ones. So again, pathology. We've got a lot of drama here, a lot of dramatic, outliers. Yeah. I mean, this might even be PEA. Yeah? Okay. But it's not a bad view. Okay, I think one more. And this is already telling you what it is. So look at the one on the left. And what looks abnormal? And I said it earlier in the talk, what makes a good view. Maybe.
Dilatation of the aorta?
Yeah, someone said, so a dilation of the aortic root. So this is an abnormally large aortic root with the sinus of Valsalva right here, compared to normal, because you've seen now a number of normal that I showed you before. So hopefully you were able to see, and this is pretty subtle, and without measurements it would be hard to do, but this is a little big. And it's possible we have mitral regurgitation for sure if we put color Doppler on it. But that was what I was asking you guys to see. Okay, so we went through some really basic pathology it's very obvious. The next thing to do with that, beyond valvular pathology, for example, is to start to think about how do we eyeball EF? Because everybody wants to know, what was the EF? So say, you just told me what normal EF is, right? And you told me that these other guys with severe dysfunction, you all called it out, is really severe and low EF. But everything in the middle, that's where we have to do a little bit more work. And that's where looking at images and doing the image interpretation over and over and over again, you're going to be able to successfully eyeball ejection fraction. And we say ejection fraction as a surrogate for left ventricular systolic function. So remember, it's not the be-all of, the cardiac function, but it's part of the story. Because I think, ejection fractions between 50 and 25 can be really hard to eyeball. And the way you do that and the way you help your learners do that is by seeing these over and over again. And so we'll leave you with this, in that simplify it when you're thinking about this, and maybe not get into the weeds at the bedside immediately. And there might be better ways that we can teach our learners, our colleagues that don't know how to do POCUS yet, where it's not so overwhelming and we're not so worried about doing it. Okay, on that note, we're going to get going, and I will have Diane take over. Is that you? Yeah, perfect.
All right, so we talked about what everybody loves, which is the heart. How many of you have done FAST exam? All right, well, we're going to do it slow. All right, so we're going to stay within this proposed framework. And I think of it a little bit like when you're learning how to interpret chest x-ray. I don't know how to drag that machine into the room and get the perfect picture or what settings to set, but I know how to interpret a chest x-ray, and that's how we're going to simplify this with ultrasound. And so we're going to start at the same place that we started with cardiac ultrasound, which is, what are we actually looking at? Does the view make sense? And so FAST exam, we're going to start looking at the kidneys, and we're going to focus on that right upper quadrant. And the other thing that's unique with FAST is we have a very specific clinical question. What's the question with FAST exam? Is there fluid? Super simple. So anything beyond that is like brownie points. And so there are really two different views that we're going to look at when we're looking at the right upper quadrant, which is long axis and short axis. So this first is when you have the indicator cephalad, is when you're going to see the long axis. And we'll have an analogy that'll either make it easier or make you hungry. So we're really fanning over the kidney in the hole here. And this is labeled to show you exactly where the indicator is and the orientation with the body. And this is actually pretty important because where does fluid tend to go? Yeah, down. Not a trick question at all. And so depending upon how you have the patient positioned, you might be more or less likely to actually find exactly what it is you're looking for, which, as you said, was... Ooh, they're fading, I think. Down, fluid, yes. All right. Here is our wonderful analogy. When you're thinking of the long axis, think of it as though you're looking at a hot dog bun or bread as a whole, the whole loaf, as opposed to short axis, which is when you're actually doing the slices of bread. And so you just have your one slice. So this is what one slice of bread looks like as you're fanning through the kidney as a whole. So this is your short axis, and you're going to be quizzed on this in the near future. So if everybody just maybe takes some modafinil, we'll be able to do this. All right, so using that framework, we're going to start with, what is this view? All right, awkward silence. We're going to wait 10 seconds. There we go. Yeah, so this is the long axis. And then we're going to throw some labels up, because then I'm going to ask you if you're noticing anything within the kidney. Well, first of all, is this a decent view? Can you see what it is you're asking? Yeah. These actually are pretty easy views to get. But you're answering your clinical question. Do you see free fluid? No. All right, do you see anything in the kidney?
I'm hearing a lot of murmurs. Anybody want to yell out?
I hear cysts, I hear stones. So this is actually a normal kidney. This is renal medullary pyramids, which is the filter for the kidney, and so they're engorged with urine. And so this is actually not concerning at all. This is a normal kidney. So already in 3 seconds, you've learned a normal variant that you might see when you're performing a right upper quadrant study. And that's what these look like. So don't immediately jump that everything that you see is a pathology. All right, what do we have here? What's wrong with this view? Yeah, you're getting some shadow. So how would we fix this? How would we interpret this? Well, this is a static image. So one of the things that's super different about fast exam is you can't get everything that you're looking at in one still picture. So you have to constantly be fanning. You want to make sure that you're seeing everything surrounding the kidney, so the superior and inferior pole. So you're never going to answer your question with one static image. So in general, this picture really doesn't mean anything to us. But now what do we see? Now we got a good picture, right? Because you can see no fluid all of the way around. And there are our nice labels. Is it normal to see the spine? Yeah. Why is that?
Solid organ.
Yeah, so because of this is all sound technology, because when those piezoelectric crystals rub together and create these sound waves, they have to have a medium that they can bounce back. So as opposed when you're looking at lung, where air is the enemy of sound, you're just working through dense material here, so you can continue to see all the way posteriorly. All right, what view is this even? What plane are we in? Yeah, short axis. Is it a great view? It's not that great. But does it answer our clinical question? Yeah, so what do we have here? Would we rush this patient to the operating room? Yeah, it depends, right? So one of the other things to remember when you're performing any of these studies is that they're not performed in isolation. So if you perform this now and then you go back and look at that same spot a couple minutes later and it's twice that, well, you might go to the operating room, especially if the patient's symptomatic. All right, so what's wrong with this patient? What view is this? Short or long? Long. You think they're okay, maybe? The labels are up, so it's not that hard. But there's something that we're seeing in the moving picture that we didn't see in other pictures. IVC, very good. So I bet you wouldn't be shocked that the first time somebody might look at this image, if they were new to reading fast and they see this hypoechoic space kind of pooling around your pole here, that they might think that's free fluid, but it's important to know your anatomy. And so that is just the IVC coming through. All right, what about this one? Let's start with at the very beginning, easy, short or long? I'm hearing short, long, short, long, short. Well, so that's the other part, doesn't matter.
Off axis.
Off axis, oblique. What's the most important finding we see here?
Fluid.
Yeah, there's a ton of fluid, right? So whatever axis it is, it's too much fluid, and this patient's probably in trouble. And we've labeled free fluid for you in case you missed it. All right, now this one's a little bit different. What view is this? It's not oblique. All right, so we're in the long axis now, and what are we seeing? Oh, I'm hearing all sorts of stuff now. Yeah, which means what? Yeah, hydronephrosis. And then we have a little extra visitor in there, and we're going to stick with, I think we're using the technical term goober for that, which is some type of renal mass in there. And then, so earlier we had the image of the renal medullary pyramids versus hydronephrosis, and you can kind of see when you have these hypoechoic spaces how that can be confusing, but just knowing your renal anatomy, and that hydronephrosis isn't in the medulla of the kidney, and that the more hydronephrosis or the higher grade you have, and here's a little characterization of that, the more cortical thinning there is. And it's dependent upon how much space is actually where the obstruction lies. And if you're doing a fast exam, this is probably not going to be the focus of what you're analyzing. All right, and what do we have here, long or short axis? Ah, yeah, so this was a trick. Because remember, we're not performing the exam, we're just interpreting it. And so sometimes when you're interpreting, you find that the image that you were expecting is not at all what is there, but it doesn't mean that it's not important to pay attention to that pathology. So I heard somebody point out the hyperechoic line of the diaphragm. So whoever performed actually slid a little cephalad with the probe and are sitting on top of the diaphragm, but we still have a finding, right? So still something potentially to do. Yeah, you could do a chest tube. You could do nothing if they're fine. You could consult somebody else to deal with it. Whatever you want to do. Depends on the patient, right? So for how often you've probably performed fast, and this is really like grassroots ultrasound with starting with fast exam, most of the time you're only looking for fluid, but you can see normal anatomic variants that occur when you're looking versus true pathology. And some of these were things that you've probably never looked at, and some were just incidental, maybe the exam wasn't performed quite right. And so if you go back to this method of keeping it very simple, you're able to give a pretty in-depth interpretation of what it is that you're seeing. And so that takes us back to this framework. What are you looking at? What's wrong with what you're looking at? And then what's wrong with the patient? So to put this whole session together, it's that don't let the probe scare you, that even if you can't perform it, you can still potentially interpret it. And not everybody is a hands-on technician. Some people are a little more cognitive, and both are okay. And POCUS rocks, basically. So if you can't perform it, then interpret it. Thank you.